So the topic given to me today was advances in the management of viral hepatitis during pregnancy. It's a very important topic because over here we are dealing with two lives, the mother and an unborn fetus. And basically the management and the treatment differs in various viral hepatitis. So moving on, I don't have any disclosures to make. The outline of my talk will be, first of all, overview of hepatitis and pregnancy, followed by a few cases, case of hepatitis B, C, and E. In the interest of time, I will be skipping hepatitis A. We'll move on to review of literature with the cases, and then CLD and pregnancy, including advanced chronic liver disease. Then, of course, safety of endoscopy in pregnancy and some take-home points in the end. So what are the challenges of liver disease in pregnancy? It's a dreadful complication in pregnant patients, basically can be life-threatening to both mother and fetus at the same time. Fortunately, majority of these are self-limiting, but in some cases, it can lead to fulminant hepatic failure. General physician and specialist hepatologists all confronted with these patients during their practice. The problem is safety of medication. The other problem is when, how, and where to refer these patients if they are seeing them in their clinics. And the problem is, again, there are two lives at stake, and timing of delivery is a critical decision for hepatologists, for intensivists, and for gynecologists. So extreme vigilance and prompt management is crucial. So this is the snapshot what is happening in Pakistan, and just like in any other endemic country for hepatitis E, Pakistan also has hepatitis E endemicity, and majority, almost half of the patients with fulminant hepatic failure in pregnancy are due to hepatitis E. So there are some physiological changes in the liver. We all know there is increase in cardiac output by 40 to 45%, basically to renal, uterine, and skin blood flow. But there is little change in the liver blood flow. And if you see that in pregnancy, ALT, bilirubin, and prothrombin time remains largely unchanged, whereas there is slight drop in albumin, there is raised of alkaline phosphatase because of placenta, and there is drop in hemoglobin because of hemodilution, and there is raise of alpha fetoprotein. So any abnormality seen in transaminases and bilirubin needs further evaluation. So we are coming up to hepatitis E in pregnancy. This is the recent WHO guidelines. And what are the key points is the prevention of maternal to child transmission is a part of WHO's core strategy to achieve elimination of hepatitis B worldwide. If you want to eliminate this deadly virus, we cannot miss out this important MTCT, basically. Universal screening of hepatitis B is a must during pregnancy across the globe. For elimination, a reduction of hepatitis B surface antigen prevalence to 0.1% in children of 5 years of age is required. Antiviral prophylaxis is needed together with vaccination, and the birth dose vaccination is very, very important. Recently, in a SAASL guidelines published last month, they have beautifully elaborated the birth dose vaccine data and prevalence. And unfortunately, in Pakistan, we don't have much data, but in a nearby country, in India, only 56% of the children receive birth dose vaccine, which means receiving a hepatitis B vaccine within 24 hours. So you can see the sad state of affairs that half of the children actually are missing out of birth dose vaccine. Timing of stopping antiviral prophylaxis after delivery in inactive hepatitis B virus mothers is debatable. Close monitoring is required for flares postpartum. So this is a very important pyramid, and basically our guidelines and our hepatitis B elimination depends on this pyramid. And if you see at the bottom, it says that at least 3 doses of hepatitis B virus vaccine, including a timely birth dose within 24 hours is required, followed by hepatitis B surface antigen testing, linkage to care and follow-up of these infants. And where available, hepatitis B immunoglobulin should be given to infants born to mothers with hepatitis B surface antigen and E antigen positive mothers. And then at the top, there is maternal antiviral prophylaxis if the maternal DNA is high or if the mother has hepatitis B antigen positivity. So we'll move on to case. It's a case of 20 years old girl, a known case of hepatitis B since birth, currently not on treatment, is getting married and has come to you for counseling and advice. This is a routine scenario in my clinic. She has several questions in her mind, which are, can her husband get hepatitis B from her? What if she gets pregnant? Are drugs safe in pregnancy? How can you prevent vertical transmission in newborn? Is it must to go for C-section or normal vaginal delivery can be taken and is an option? Can she continue breastfeeding? So these are all genuine questions that patients on time-to-time basis or their parents generally ask. So what test will you order? Of course, we'll do some baseline investigations. We'll do PCR. We'll check for Delta. We'll go for ultrasound abdomen. We can go for fibroscan, but in pregnancy and if it's later stages, the liver stiffness would be increased and the fibroscan might be not a true picture. Family screening is important. If the husband is not vaccinated, you have to check for husband's hepatitis B and you have to get him vaccination. So the transmission occurs via parenteral or mucosal exposure to infected body fluids. In countries endemic for hepatitis B, perinatal exposure accounts for the most transmission in newborns. The risk of developing chronic hepatitis is inversely related to the age of infection. So earlier you get the infection, more chance that these children will go into chronicity and will develop to chronic liver disease and further complication in their lives. And across the globe, the WHO, the CDC, and all gynecological society recommend screening for all pregnant patients for hepatitis B virus with surface antigen, at least once in their pregnancy. So the course of hepatitis B virus in pregnancy is similar to that in general population, which is a good thing. And the risk of FHF after acute infection is less than 1%. No association has been found with hepatitis B and intrauterine growth restriction or preeclampsia in meta-analysis or in large trials, although in few trials they have shown that there is some chances of increased gestational diabetes or intrauterine growth restriction, but per se, by and large, in most studies, it's not related. So when you test hepatitis B in pregnant woman, if she's positive, then you have to check for the viral DNA. And in some cases, if suppose viral DNA is not available in rural areas or in district hospitals, then you can go for E antigen also as a substitute for viral DNA. If the viral DNA is less than 200,000 international units and E antigen is negative and the patient is not cirrhotic in our case, so no maternal tenofovir prophylaxis is needed, and we have to defer long-term maternal tenofovir treatment, but we have to reassess this patient periodically for any flares. If the hepatitis B DNA is more than 200,000 copies and E antigen positive, but without cirrhosis, then you can start maternal tenofovir TDF from 28 weeks of pregnancy and at least till birth. And then you have to reassess for long-term maternal TDF treatment after delivery and monitor as per your local guidelines. Then if the patient has cirrhosis or is cirrhotic, then the cutoff value of DNA is much less. It's more than 20,000. And plus, if there is persistently elevated ALT, then you have to start long-term TDF. When in cirrhotic patient, you don't stop because then there's a risk of decompensation. What about the infant? At hepatitis B, birth dose vaccination within 24 hours is required, followed by 2 or 3 doses of vaccine. And if available, immunoglobulins should be given to all hepatitis B surface antigen positive mothers. So this is the treatment algorithm that we follow. So what are the medications that can be given in pregnancy? Basically, there are just two medications, telbuvidine and tenofovir, which comes in category B. We don't give telbuvidine because of resistance problem. So the only options we have is tenofovir. So why tenofovir? Because there is minimal risk of resistance during treatment and there is high efficacy in preventing mother-to-child transmission with no adverse effect. But we have a new medication, which is tenofovir alafenamide. And what about the safety of TAF? Recently, last month, there's a multi-center prospective trial which was published in Clinical Gastroenterology and Hepatology. It was done in Chinese population, and they have taken two arms of almost 100 patients in each arm, and they followed these patients for 2 years. And they give, in one group, they give TAF, the other group received TDF. And they found that only one patient had, in TAF group, had underwent abortion due to fetal cleft palate and lip and palate. And they said it is probably a non-causal, non-causal effect. And they did not think that it is because of TAF. So in the conclusion, they said it's generally safe and effective for pregnant women. That definitely we need more trials like this before it can be recommended as a routine in pregnant patients. So breastfeeding is not contraindicated. The woman can continue breastfeeding, although there are some data that antivirals are minimally excreted in breast milk, but it's less likely to cause significant toxicity. So what do you recommend of women with hepatitis B who desire pregnancy? So if woman with mild disease and has low viremia, pregnancy before treatment, you can monitor these patients and they can become pregnant. But if the woman has with moderate liver disease and no cirrhosis, so you treat them before pregnancy. If there's response and the target is achieved, you can stop. If doesn't, you can continue the treatment during pregnancy as well. Women with advanced liver disease, treatment before, and you need to continue during pregnancy and even after delivery. Women with mild disease and very high viremia, treatment in last trimester after 28 weeks with category B drugs. So this is usually a very useful points that you can, use on daily basis in your clinic. So this was a short communication paper which I wrote and mentioning all the challenges on day in and day out we face in our clinics and wards, basically. Moving on to hepatitis C in pregnancy, basically. So again, Pakistan is an endemic zone, basically. You can see, and we have a huge burden of hepatitis C in Pakistan, and it's on the second number 2 after China. Pakistan comes in the hepatitis C burden. And there are various issues, basically, and there are various manuscripts, and we have a lot of problem in making this, decreasing the prevalence of hepatitis C, because at the government level, there are problems. In Pakistan, the reuse of injections is a problem. Safe blood transfusion is a problem. In fact, in Southeast Asia and Southern Asia, these are the major problems: lack of awareness, lack of funding. So this was a paper which was published, a few years ago, mentioning all the problems that are having and the barriers of effective hepatitis E elimination, because we need to speed up our efforts. Otherwise, the target of 2030 will not be met. And further, because of this COVID, this has deterred our expectancy and the probability of achieving hepatitis B and C elimination by 2030. So this was the publication which I published last year, that can we eliminate hepatitis C from Pakistan by 2030, or it can become a second polio for Pakistan. So these are all the problems which are there mentioned in this manuscript. So this was the case. It was a 32 years old pleasant lady, banker by profession, came to my clinic for counseling and further management of hepatitis C as she's getting married soon. She was treated with pegylated interferon and ribavirin in 2013. There was family history positive for chronic hepatitis C without history of HCC in the family. Her current labs in ultrasound showed that she has compensated disease. She has CLD, but it's compensated, and it's class A cirrhosis. And currently, her hepatitis C PCR is positive. Again, she had several questions regarding her disease. So what is the risk of maternal to child transmission of hepatitis C? How risky will be the pregnancy in her case? Although she's stable, but she has liver disease and it's compensated. Does she require treatment before, during, or after pregnancy? Safety of medicine during pregnancy. What harmful effect does this virus has on unborn child and afterwards? Does she require endoscopy preconception and its risk during pregnancy? Outcome of pregnancy in her case. And what about the mode of delivery, whether C-section or normal vaginal delivery? So again, for hepatitis C, it's a universal screening, which is endorsed by AASLD, CDC, and WHO. And it basically allows appropriate assessment of liver disease and linkage to care after delivery. It allows screening and care of exposed child. So this was the reason that it's appropriate to do universal screening. It also enables application of special recommendations for hepatitis C virus pregnant patients, like preference of amniocentesis over chorionic villus sampling if needed, avoid internal fetal monitoring during labor, and avoid prolonged rupture of membrane. So if you see the data, it was a pooled data from National Notifiable Disease Surveillance System. And if you see over the years, the prevalence of hepatitis C, the numbers are increasing, especially in childbearing age, in ages between 15 and 44. The graph is slowly and steadily is climbing up. So case number is becoming higher in younger versus older women since 2013. So what about, is it cost effective that you have, if you are screening universally, this means that almost 5 million pregnant women in 2018 could result in detection and treatment of an additional 33,000 women and 300 children born with hepatitis C. In this cost effective analysis ratio, what they found out that yes, it is cost effective to get this hepatitis C antibody test done in all pregnant women, regardless of low prevalence areas and across all fibrosis stage. So yes, it is cost effective and we should do it because it will save us from long-term complication and treatment economically in these patients. So what is the effect of hepatitis C infection in pregnancy? Hepatitis C virus may have negative effects, but difficult to tease apart from effects of associated factors. These are the two large studies which was conducted over various million of patients. And what they found out that yes, there is chance of increased preterm birth, intrauterine fetal growth restriction, low birth weight, and of course, late neonatal death. All are correlated with hepatitis C, and those women having hepatitis C have increased chance of having these complications. So those patients who have hepatitis C also have a higher chance of intrahepatic cholestasis of pregnancy. Again, this was another study done in Sweden, around 11,000 women. And what they found out, women with hepatitis C has a higher chance of, having intrahepatic cholestasis as compared to women without having hepatitis C. And also in another meta-analysis of 3 studies, there is higher chance of ICP in pregnancy. So despite recent advances in pathogenesis and treatment of hepatitis C in pregnancy has been a neglected condition, and improved public health response in these population is needed. Hepatitis C generally does not reduce the likelihood of women becoming pregnant unless there is advanced cirrhosis. If there is advanced cirrhosis, then the fertility rate decreases. Otherwise, per se, if the woman does not have cirrhosis, just having hepatitis C does not reduce the likelihood of fertility. So much remains unknown about the dynamics of hepatitis C infection during and after pregnancy, as well as in the neonatal period. No clinical intervention has been clearly studied and proved to reduce the vertical transmission risk. Vertical transmission is the leading cause of childhood Hep C infection in the developing world. So the worldwide seroprevalence of hepatitis C in pregnant women is thought to be anywhere from 0.1 to 2.4, but it's much higher in Egypt, where it is estimated to be as high as 8.6%, but vertical transmission is low. In spite of high hepatitis C positivity in pregnant population, the rate of vertical transmission, fortunately, is low. It's 2 to 8%. Hepatitis C mono-infected pregnant have 2 to 8%, but when they have HIV together, then the risk of transmission to newborn increases to 2 to 4-fold. So in those areas which HIV endemicity area, we need to check HIV as well. Luckily, in Pakistan, there are certain pockets where HIV is present, but in majority, the incidence of HIV is quite low in Pakistan. So the mother to infant transmission of hepatitis B can be intrauterine, intrapartum, or postnatal. So again, this is a very important meta-analysis of risk of transmission from mother to child and by serostatus. And you can see that if the patient is HIV negative, the transmission rate is almost half as compared to those who have hepatitis C and HIV in co-infection. So high viral load holds increased risk of vertical transmission. Vertical transmission increases if the maternal serum HCV viral load is above 10⁶ copies. And the maternal, in the pregnancy, basically, the Hep C RNA viral load fluctuates. So it's recommended to repeat the hepatitis C virus RNA load in the 3rd trimester. There is no effect of genotype on vertical transmission. So what about the mode of delivery? More controversial is the effect of mode of delivery on vertical transmission. A few studies in the past recommend the use of elective C-section to prevent possible obstructive risk in order to lower the incidence of hepatitis C vertical transmission. But then this study was followed by a large multi-center research project in Europe, which failed to show significant evidence to prove its protective effect. And if there are no obstructive complications, just patient having hepatitis C is not an indication that the woman should go for C-section. So again, this is the maternal prevention after pregnancy, during and after pregnancy. So there were various studies and did not show that elective C-section is better as compared to vaginal delivery. And then there was a study, 3 cohort studies that showed invasive fetal monitoring versus none. And then again, the results were mixed, inconsistent, that few of the studies were in favor that yes, it causes a maternal to child transmission, and the other said that there is no risk. Prolonged rupture of membrane, basically, yes, there is clear-cut evidence that if the membrane rupture is more than 6 hours, there's increased risk of transmission. And all studies showed that there's no association between breastfeeding a woman with hepatitis C and transmission to infants, so it's safe and the woman can continue breastfeeding. So what about the perinatal transmission? Consider children born to hepatitis C positive mothers infected when hepatitis C RNA is detected in at least 2 serum samples and at least 3 months apart during the first year of life. And hepatitis C antibody is positive after 18 months of age. Testing of hepatitis C antibody is of limited value before 18 months because there is passive transfer of maternal antibodies. So try to avoid checking newborns before 18 months, basically, because you will get the false result and this will further cause, anxiety to parents and will lead to unnecessary tests. So most common cause of hepatitis C virus in children is basically perinatal, and 25 to 40% of infants clear hepatitis C by 2 to 3 years of age. Impact of hepatitis C infection in children, there is reduced quality of life, there is reduced physical functioning, there is even in some studies, there's reduced executive function impairment in almost 20% of the patient. And in some studies, they have found correlation of children with hepatitis C and worsening of cognitive functioning. And together with children, there is also poor, parental quality of life and parental emotional impact, basically. Higher rates of cirrhosis in children who acquire hepatitis virus through vertical transmission. And HCC is the second most common hepatic malignancy in children. So for the woman, it is basically recommendation is that all women of reproductive age with known hepatitis C virus infection, antiviral therapy is recommended before considering pregnancy, whenever practical and feasible, to reduce the risk of hepatitis C virus transmission to future offspring. So if the patient is getting married and she was positive, so it is advisable to give her treatment, because now we know the treatment is 3 to 6 months. We need to counsel about benefit of antiviral treatment before pregnancy. Ribavirin is contraindicated in pregnancy due to teratogenicity, and after completion of treatment, you have to wait for at least 6 months, which is the washout phase, before she gets pregnant. So you have to counsel them as this thing as well. So what about the safety of DAS in pregnancy? There is some initial data, basically. And if you see, almost majority of the studies are done on animal models or on rats, basically. And if you see that ledipasvir and sofosbuvir, there's No birth defects was noted and was seen relatively safe as compared to velpatasvir and sofosbuvir combination. So we need to have human trials. I know this is a very difficult group, and the ethical committee gives, it's the approval it's difficult to get ethical approval in these patients where we are dealing, with two lives, but we need human studies in order to put DAs in safe in pregnancy. So this is the one study which is recently, published, but it is um, done on a very small number of patients. Just 9 patients were enrolled who got pregnant and who received ledipasvir and sofosbuvir, and 8 were included in the analysis. It's a very small number basically. And what they concluded, it was safe and effective. So we need these type of study, multi-center randomized controlled trial in future. So what's the treatment algorithm like? In mother, you have to treat before pregnancy. But if she gets pregnant, you have to monitor. You have to do post-delivery. You have to wait till she finished her breastfeeding, and then you can continue after breastfeeding. In child, you have to wait in infancy, but once the patient reaches 12 years of age, you can start antiviral treatment, or at least 35 kgs of weight. So moving on to hepatitis E in pregnancy. So again, if you see the map, hepatitis E is endemic in Pakistan, or we have at least 4 outbreaks in the past with hepatitis E. So this was the case of 25-year-old lady, gestational amenorrhea of 29 weeks, presented with 2-day history of irritability and confusion, jaundice. There's yellow discoloration of skin, sclera, and dark-colored urine. No clear-colored stools or itching. There's no history or abdominal pain or fever, but there was history of decreased appetite. So she was widely stable, slightly tachycardic. The oxygen saturations were borderline, and there was flapping tremors present. On examination, there was generalized tenderness present. Bowel sounds were positive. The fundal height palpable was 28 weeks. There was no evidence of free fluid in the peritoneal cavity. So labs were high WBC count. There were platelets were normal. The bilirubin was high, mainly conjugated. ALT was high. Serum albumin was low, and PT was high. So the diagnosis, the ultrasound was normal echo texture, 16 centimeter, normal spleen, and mild ascites present. There was intrauterine, unfortunately, fetal demise at 29 weeks. So we did viral serology, and the viral serology IgM turned out to be positive. The rest of the viral serology was negative. So the final diagnosis was fulminant liver failure due to acute hepatitis E with intrauterine demise. So the hepatitis E and pregnancy, it has multiple factors that affect the mother and the newborn. And basically, if you see, it's basically genotype 1. And because of the high viral load, there is placental and fetal interface hepatitis E, and there's efficient replication because of immunocompromised state in pregnancy. And because of the hormonal changes, there is high estrogen, high progesterone, and high HCG, which causes high viral production replication. There's high interleukin 6 basically, and high interferon gamma. And then there is mutation of progesterone receptor gene. There's vertical transmission, transplant placental, and break in maternal fetal barrier, which is causing fetal neonatal hepatitis E infections, basically, and death of fetus, basically, with hepatitis E. Then there are various followed by obstructed fetal and neonatal events. And because of this hormonal changes, there's immune dysregulations, which causes high interferon gamma and interleukin 6. There's low CD4 count and high CD8 count, basically. And in developing countries where this virus is endemic, most of the female in India, Pakistan, Bangladesh, we all agree, are nutritionally depleted right from the beginning, from the birth. So basically, because of cultural norms, they are not fed properly. So because of malnutrition, these things become worse. And again, they sometimes have co-infection, especially with bacterial infection. And these all multiple factors come into play, leading to hepatitis E and acute liver failure and demise of the newborn. So there's an interesting concept of mirror syndrome. And what is the mirror syndrome? And maternal DIC and hepatic encephalopathy due to toxic metabolites produced by fetus with acute liver failure. Better survival, rapid recovery from acute liver failure in mothers who delivered early on expectant basis. Long gestational period after onset of coma, dangerous for mother. DIC limited to mothers who delivered babies with ALF, not normal or non-fulminant hepatitis. So how do you treat if the patient has acute hepatitis C? Is supportive treatment. There is debatable data that early delivery versus normal delivery, but in acute hepatitis per se, you need to closely follow this patient. But things changes when there is fulminant hepatic failure, because of course we have to save the mother first. So early delivery, especially if the mother is comatose or if the mother has hepatic encephalopathy, we have to treat complications of fulminant hepatic failure. And sometimes if the patient is not getting better even after delivery, then early liver transplantation. What about infants born to mothers infected with hepatitis C? There's no specific treatment or recommendations exist. Close observation of the infant is advised. So when we talk about hepatitis E, it's important to mention hepatitis E vaccine as well, which is Herculine. And it is a Chinese vaccine. Basically, the trials initially was done in China, and it's available in Pakistan. One good thing is, although it's not FDA approved as yet, and it is expressed in E. coli-derived hepatitis E virus genotype 1, it induces a vigorous T-cell dependent antibody response. It's basically commercially available 30 microgram dose intramuscularly administered 0, 1, and 6 month regime. And at 4.5 years, vaccine efficacy reaches up to almost 90%. And it is approved from ages 16 to 65. Cross-protective efficacy of hepatitis E virus genotype 4 is predominant genotype in the region of study. So what about, should hepatitis E virus vaccine administered during pregnancy? Is it safe? We don't have data right now, and it's not approved to administer hepatitis E virus in pregnancy. It is advisable to give this vaccine in a young woman with childbearing age above 16 years of age. But in retrospective analysis, they found out that some of the pregnant patients were given this vaccine inadvertently. And then they found out that when they compiled the data, they did not found any adverse event or any congenital malformation in those pregnant patients who received first, second, or third dose. So they said it might be safe in pregnancy. There is a trial currently going on, I think, in Bangladesh. We are waiting for the results, that once the results are out, we might be more confident that yes, it might be given in pregnancy, but till date, we have to give it in women with childbearing age. So this was the review by WHO in their meeting strategic advisory group of experts. And you can see that changes. This was the statement in 2014 regarding vaccine, and this was the last, which was a last meeting in November 21. And now the WHO is recommending this vaccine to prevent infection as a priority list, and because especially in women with childbearing age and in endemic countries. So these are the couple of manuscripts that I wrote and highlighting the importance of various genotypes, variants, and how to manage, and what are the current existing knowledge gaps. This was the article which was published a few years ago, and again it was data on 400 patients, and we found that the mortality was high in chronic liver disease patient. They had acute on chronic liver disease and in pregnancy both. So what about pregnancy and advanced liver disease? So pregnancy is uncommon but not rare because of reduced fertility in advanced liver disease. It's not contraindicated in this group of patients. Poor fetal outcome is increased and includes fetal demise, intrauterine growth retardation, prematurity, and high cesarean rate. So these type of patients should be referred to a tertiary care center where proper ICU facility and hepatologists are present. These patients should not be delivered at home or at villages or district hospital. There's a poor pregnancy outcome correlated with MEL score of greater than 10. So higher the MEL score, the a poor chance of pregnancy outcome. Maternal mortality can reach up to 7.8%. Preconception endoscopy for variceal surveillance and eradication is advised. Primary prophylaxis with endoscopic band ligation may be performed in second trimester. So what about the mode of delivery in advanced liver disease? Coagulopathy is a major concern at this time. So you have to correct coagulopathy and plan delivery. It requires an individualized plan. The hepatologist, the intensivist, the gynecologist, and the patient, they have to, discuss, and it has to be, decision should be made on individual basis, basically. And it all depends upon the degree of liver function, the MEL score, presence or treatment of esophageal varices, as well as patient and obstetrician preference and how comfortable they are in which type of delivery. If prophylactic EVBL is not done, then elective C-section is usually preferable. For vaginal deliveries, consideration should be given for early epidural anesthesia, shortening of the second stage, and assisted delivery. General anesthesia and surgery is poorly tolerated in cirrhotic patients. When we always say that there is a light at the end of the tunnel, and despite against all odds, one of my patients who had advanced decompensated liver disease due to hepatitis B virus with portal vein thrombosis has, uneventful pregnancy, normal delivery, and both the mother and the fetus was well. So what about endoscopy in pregnancy? So there's limited data on safety and effectiveness of endoscopy in pregnancy and should be deferred until second trimester is possible, because second trimester is the most safest trimester if you want to do procedure. Ensure hemodynamic stability and oxygenation, aggressive hydration to avoid hypotension. Left lateral position to avoid vascular compression. Meperidine is category C and propofol category B can be used for endoscopic sedation. Benzodiazepines are category D in pregnancy and should be avoided. So this was a publication I did a few years ago regarding safety of endoscopy and its outcome. And if it's properly indicated, you can go for endoscopy. But for borderline cases, it's better to avoid during pregnancy. So with proper indication, it can be done in second trimester. So what are the take-home points? Guidelines have been updated to recommend hepatitis B and C screening for all pregnant women, initiating hepatitis B treatment and 28 weeks of pregnancy with high maternal viral load to reduce maternal to child transmission. More data required on safety of TAF during pregnancy. Availability of birth dose vaccine is the key, and it should be present if we want to eliminate hepatitis by 2030, especially in developing countries, because hepatitis B is now a totally preventable disease. Hepatitis C treatment recommended before pregnancy for women of childbearing age. Hep C treatment during pregnancy is not currently recommended in guidelines. Lactation is safe in this patient. Multidisciplinary approach required in pregnant women with advanced CLD patients. Screening endoscopy, if indicated, can be done in second trimester. Hepatitis E in endemic area is still the leading cause of pulmonary hepatic failure in pregnancy. Safe and effective vaccine is required worldwide for women with childbearing age and pregnant females. So these were the three well-known researchers who invented hepatitis C and got the Nobel Prize in 2020. And taking this opportunity further, I would like to invite you all for a 4th annual conference due in first week of June. Thank you for your attention.